Um, Good morning, afternoon, evening, everyone. My name is Sadanah. I'm a professor of surgery here at Utah, and I welcome you to this session on global surgery as a satellite session for CUGH. I'd first like to just recognize Dr. Catherine DeVries, who is one of the lead organizers of this event and the founding director of the Center for Global Surgery at the University of Utah, the oldest center in the United States, as well as Dr. Ray Price, who is the most recent director and handed over the position to me and is now vice chair for global health and is an exemplary for showing sponsorship and sponsorship in global health, which is very much in need. That being said, all three of us are excited that many of you are here from all around the world. We hope you find the session very stimulating. We look forward to interacting with you. I'd like to now introduce Keith Martin, who is the founding executive director of the Consortium of the Universities of Global Health. Between 1993 and 2011, Dr. Martin served as a member of parliament in the Canada's House of Commons. He's held portfolios in foreign affairs, health, environment, defense, and international development. And he's a member of the Queen's Privy Council for Canada. With that, I'll pass this on to Keith Martin.
Thank you so much, Dr. Jerman. I really appreciate your very kind introduction. And I'd like to welcome everybody to the 4th annual Global Surgery Day, the first of 2 half-day satellite sessions. So you have to attend tomorrow's half-day session also, which is going to be another outstanding day that I know you will find incredibly valuable. The title, Bridging Gaps in Empowering Global Communities and Global and Surgical Ecosystems, really stemmed out of a meeting that some of the organizers for this surgical day, conversations we'd been having for a few years. So for those of you who don't know, how did this day actually start? So for many years, a number of us, Doctors Catherine DeVries, Mamta Swaroop, John Mira, Ray Price, Gurma Tafira, James Kobe, Sherry Wren, Walt Johnson, and a number of global surgery leaders, we'd all been trying to figure out how do we overcome the silos in global surgery, and how do we move forward by bringing groups together as a surgical ecosystem. So we were all attending the American College of Surgeons meeting about 5 years ago, literally standing outside a room of a session we'd attended, and we all decided, why don't we have a global surgery day and do it the day before CUGH's annual conference? And hence the first global surgery day was born. So it took literally 2 sessions. So by the second global surgery day, the day was fully booked. And I walked through the sessions, and people were excited. Different disciplines were coming together. But we had some very specific goals when we started this effort. And they're as follows, if I can share those with you. The first was, above all else, how are we going to increase access to quality, affordable global surgery? The second is we wanted to strengthen not just surgery, but we recognize that we have to strengthen the surgical ecosystem. And we were all committed to trying to make sure that this was an interdisciplinary effort. We wanted to break down silos in that effort to accomplish that goal. And we wanted to make sure that global surgery was at the center of all discussions about international development, poverty reduction, global health, as what we all know is that global surgery is an essential pillar of an effective health system. And frankly, you're not going to meet the sustainable development goals without having access to a quality, affordable, and effective global surgery. So hence this Global Surgery Day was born. I think all of you know so well, otherwise you wouldn't be here, that you know the terrible suffering that your patients and families endure when there isn't when there is a lack of access to surgery. It is a preventable problem, and is one that you're all committed to overcoming. We also know that the need for surgery is going to increase as non-communicable diseases rise. We all know that NCDs are responsible for 70% of deaths worldwide, the leading cause of morbidity. And I have to share you, I share this, this is 5 years, this is the Lancet Oncology commission that came out. It was Lancet Oncology, the journal. And this was on access to global cancer surgery. It's 5 years old, but it brought to mind and continues to remind me, I keep it behind me, of the absolutely essential nature of global surgery in all of what we do, regardless of what our disciplines are. I hope that what you will do is be able to attend tomorrow's session, attend our other satellite sessions. They're all free, and there are 30 of them that finish on the March 11th. I hope you'll also attend our conference on March 12th to the 14th. You can access that all on CUGH2021.org. And finally, I'd like to thank the two groups. One is the sponsors, which put this together, the University of Utah Center for Global Surgery, the Association of Academic Global Surgery at Baylor College of Medicine, Houston Global Health Collaborative, Johns Hopkins Medicine, the Sadanah Trauma and Surgical Initiative, Incision. And above all else, none of this would happen without the hard work of many people. So I'd like to center out and make sure we all put our hands together to thank my friend, Dr. Catherine DeVries, my friend, Dr. Mamta Sarup, my other friends, Dr. Jim Cobry, Dr. Madani, Dr. Jenny, Dr. Bunzel. Thank you very much for all of what you do. You have been leaders in surgery, but above all else, you've put patients and patient care and the care of those who don't have access to surgical care above all else. So you're my heroes. I thank you on behalf of all of us at CUGH, and I hope all of you have a wonderful day. Join us in Los Angeles, April 1st to the 3rd, 2022, when we'll reconvene for our next CUGH Global Health Day, and also hopefully the 5th annual Global Surgery Day. Dr. Jaraman, over to you, and thank you.
All right, thank you, Dr. Martin. That was excellent. My name is Daniel Rhee. I'm a pediatric surgeon at Johns Hopkins Hospital in Baltimore, Maryland. On behalf of our whole organization, as everybody heard, we'd like to thank everyone for coming. And again, while we wish we could see everyone in person this year, this virtual platform has really allowed us a unique opportunity to increase really everyone's access to this conference and bring people in from near and far away who would not have been able to attend this conference otherwise. So as a result, we've had I think the highest attendance yet, and just hope to build from this for years to come. As Dr. Martin already mentioned, our sponsors, we'd also like to thank our partners in this event. They do include Operation Smile, the American College of Surgeons, Operation Giving Back, the G4 Alliance, Smile Train, Lifebox, the Pan-African Academy of Christian Surgeons, Loma Linda University, the Program in Global Surgery and Social Change, the Consortium for the Universities in Global Health, of course, and Incision. I'll pass it on to Yumna.
Good morning. Hi, I'm Yumna Sharif. I'm a PGY3 general surgery resident over at Baylor College of Medicine. I'll just be going over some housekeeping rules for virtual platforms. So please leave free comments in discourse. The social media tag that we'll be using, hashtag Global Surgery CUGH and hashtag CUGH2021. The meeting is being live translated into Spanish. Please see the translation button on the toolbar. It's the right-hand corner. It looks like a globe and says interpretation on it. The meeting is also being recorded. We hope you enjoy the sessions today, and don't forget about the Association of Academic Global Surgery meeting to follow the sessions. And of course, there is a day 2 to look forward to. Thank you.
Good morning. With that, I will be presenting our very first speaker for our feature presentation on asset mapping. Katayun Madani is a Global Surgery Research Fellow at the Sadanah Trauma and Surgical Initiative. She is concurrently completing her master's in public health at St. George's University and is chair of Incision. She is a co-founder and the first chair of Incision Grenada and led Incision's research team from 2017 to 2020. She also served as Incision's chair in 2020. She found Students for COVID, bringing together 45 countries to connect, share, and verify emerging information regarding the COVID-19 pandemic. Dr. Madani.
Thank you so much for that, Dr. Swaroop. Going to change the slides. Thank you, Dr. DeVries, Dr. Swaroop, and all the organizing committee for the opportunity to present. In global surgery, we often begin our collaborations on needs assessments, where we look for gaps to bridge and spaces to fill, negative spaces to fill. The issue with this outlook is that we begin a partnership and a collaboration in an unequal footing, where one partner has all the haves and the other the have-nots. One has the needs and the other is the savior. Academic global surgery involves the application of research, education, and evidence-based advocacy towards clinical surgical care in regions of health inequities, with the primary goal being infrastructure development with the delivery of high-quality surgical care to all, whether in high, middle, or low-income countries, or in urban and rural locations. In academic global surgery, we strive for just and multi-directional collaborations. And with that in mind, I'd like to discuss asset mapping. Asset mapping involves an outlook of resources that are currently available within a community on a map. Oftentimes, when we discuss assets, we think of money, gold, land, valuable things. In global surgery, I would argue that one of the most valuable assets is the people, the workforce, the community members, and the relationships between them, the patients, as they are not only the core of global surgery, but they are also decision makers within their own communities. Think of wildflowers. No one is running on a daily basis to purchase wildflowers from flower shops. However, in nature, wildflowers support bees. And bees, by their cross-pollination, support our entire natural habitat and ecosystem. Wildflowers are an invaluable asset to our natural ecosystem. That outlook and looking at assets first can also bring about a different view that perhaps within a community, what already exists can be repurposed and redistributed to support the infrastructure and strengthen it. And that perhaps it is not always necessary to bring in new solutions or new resources to the environment. An example of that is the COVID pandemic. If you think back over the last year, the entire world faced a crisis of shortage of resources, supplies, and workforce. In dealing with this crisis, what is noticeable is that majority of the high-income countries had a serious struggle, whereas the low and middle-income countries were able to handle this better. Perhaps the reason behind this is that low and middle income countries have a know-how of managing resources that are limited and using those resources to take care of large population of patients. Whereas in high-income countries, we are used to an abundance of resources, and our system is set up based on that. This is a valuable lesson for all of us to take away from this pandemic. Another viewpoint on this lesson is that perhaps solutions that are necessary for an infrastructure already exist within the community, and that not every solution from an external environment is suitable for every community. There are no one-size-fits-all solutions. So in global surgery, in academic global surgery, we should strive for partnerships that are equal, not only equal in footing, but from the beginning, multi-directional, where all partners involved have resources and assets shared and benefit mutually from the exchange. Perhaps it is time that we shift our view from needs assessments to asset mapping and the resources available. And perhaps it's time we take a lesson from the nature where mutualism has been the most beautiful form of symbiosis and collaborative work.
That face that is usually covered by her phone has finally made an appearance.
I think I'm having a difficulty sharing. Are you able to see the video? No. Allow me to reshare this. I apologize for this technical difficulty.
Kind of symbiosis is called mutualism. This is where both parties get something out of the deal. For example, take this hermit crab. She has a garden of small anemones on her shell that she carries everywhere she goes. The anemones give her protection from predators like octopus because their stinging tentacles pack a punch. But the anemones have a great life living on her shell because they gather some of the scraps from her messy eating and they travel around with her to the next meal. Since the hermit crab uses an old snail shell for a home, she needs to find a larger shell every once in a while as she grows. When she finds one, it's as simple as hopping out of the old shell and into the new one. But what to do about the anemones? The anemones are so important to the hermit crab that she must also move them to the new shell. Without them, she's defenseless. Slowly, with a combination of tapping on the anemones and peeling their edges, the hermit crab convinces them to release their grip. Only the crab knows how to coax the anemones into letting go. They will not submit to any other creature pulling on them. Once the anemone lets go of the old shell, the hermit crab deposits it on her new shell. She simply plops it in place and holds it until the anemone grabs on. The anemone will then crawl around on the shell and find a good spot all on its own, while the hermit crab turns her attention to working on the next anemone. 15 minutes later, with the anemones planted on her new shell, the hermit crab has completed her move. She leaves her old shell for the next hermit crab, a bit smaller than herself.
This is our home.
So with that, we are ready for session 1. So session 1 is titled The Assets of the Surgical Ecosystem. This session will be moderated by Dr. Catherine DeVries, Dr. Yajer Maker, and Dr. Eric Etchell. Dr. Catherine DeVries is a professor of surgery and urology and associate professor of family medicine and public health at the University of Utah School of Medicine, and she is the founding director of the University of Utah Center for Global Surgery, as well as the founding director for International Volunteers in Urology, which is now called IVUMED. And this organization supports on-site urological education in over 20 countries. Mr. Yajer Maker is an MD PhD student in his first year as a bioengineering graduate student at Rice University with eventual hopes to pursue global surgery. He has helped develop and translate affordable designs for low-cost medical devices through his startup, World Care Technologies, and his current work in Richard's Cortum lab. Dr. Eric Etchell is a fifth-year general surgery resident at Johns Hopkins Hospital. His research and clinical interests are in cardiac surgery and global surgery. He has conducted health systems research in sub-Saharan Africa and South America and has been involved with the ACS Kaseksa Surgical Training Collaborative in Hawassa, Ethiopia. Dr. DeVries, I'm passing on the mic to you.
Thank you so much, and welcome to everybody for this CUGH surgical satellite session. It's really exciting to see how many people have joined it, and I'm really just thrilled to see how it's turning out. We have wonderful, wonderful panelists and participation. So first I'd like to mention in that video that you just showed, Kathy, that the surgeons and anesthesiologists and perhaps medical students and nurses among us saw some pretty great veins in those hands. And you know, you love to see hands like that if you've ever started difficult IVs. That's just our little perspective when we see images like that. So we are in the year 2021. The year 2020 was unique because it allowed the first time discussions and reflections of justice and equity in surgery. This is a thing we haven't done before. Many of us have come from our own personal backgrounds to learn the craft. Whether we were in medical school, nursing school, we might have come from families who had surgical problems. Maybe our relatives or a mentor was involved with surgery, but we came to the surgery space from somewhere. And very quickly, we start learning the craft. And that means we learn to do surgery, to support surgery, to be part of this whole ecosystem. And it's so very easy early on to focus on the doing. And that's important. It's important for us to become experts at what it is we intend to do. We have to serve our patients with this expertise. We learn the clinical indications, the technical skills, and the objective outcomes. And the temptation and part of the problem is that we very often focus on the objective skills. So if we come from the community with its culture, its knowledge, family support, and its own spirituality, and all of these are geographically different. What's true in North America is not true in sub-Saharan Africa, is not true in South Asia and every other place. But we bring all of that into a hospital environment that we have sometimes called the surgical ecosystem. Most of us who have gotten into surgery don't know too much about the surgical ecosystem. We don't learn this in medical school or nursing school. We don't know very much about how the whole hospital that we work in, because surgery happens in hospitals, we don't know how it works. And many of us from high-income countries take for granted that there will be electricity, diagnostic services, laundry, even food for our patients, medications, and that sort of thing, all supplied by the hospital. People who live in other countries can't make those assumptions. They don't necessarily have electricity, or at least not 24/7. The patient's families might need to bring the food. Patients themselves might need to go procure the medicines or the consumables, the gloves, the IVs. They may need to go out and get this stuff before they can have surgery. We also, as clinicians, very often don't think about all of the other public health parts that are necessary to make the whole system go. We need clean water. We need diagnostics, including laboratory, and we'll hear more about that from one of our panelists today. So we come into the system as practitioners from the community. We sometimes get caught up in this hospital big orange thing we have called the ecosystem. And we sometimes don't even get out of it to see again our patients. But our patients derive a certain value from what we have to offer. They come into it with issues sometimes of trust, often of trust. They come into the hospital, they take off their clothes, they go to sleep, they become about as vulnerable as people can be. And then they are hoping to be better as they leave and go back to their communities where they will need to recover and heal and hopefully something better after they have had their experience with us in medicine. People in the community have a different perspective. They show up in pain. Sometimes they've discovered a scary lump. Sometimes they've been born with a birth defect. People are anxious and they come into this surgical ecosystem trusting that their providers, and by providers, I don't mean just the surgeons, I mean everybody from housekeeping to the technicians who keep our instruments sterile, to the nurses who manage practically everything. They trust that what we do well. It's a black box for most of the community. And as we start to open up this black box and share, we can start to get to the value that patients expect and that we expect out of our system. So now it's a good time to hold the space, to look at the existing inequities that we have within surgery and within healthcare in general. We want to bring in and value the diversity and various vantage points, because these, as Kathy has just said, are assets. How can each member of the surgical ecosystem individually and collectively integrate and leverage these assets to provide better surgical care with justice and equity in healthcare in general? And as we know, surgery is an individual part of healthcare. We have asked our panelists to answer some questions. We want them to answer how we as members of the surgical ecosystem can improve patients' relationship with their own health. We've asked our wonderful panelists this, and our panelists come from many different perspectives. I'm sure you'll enjoy them. Most of them are not surgeons, but they bring valuable pieces to our surgical ecosystem. And I hope you will enjoy their videos and ask questions. Our other moderators have some questions, and we invite you to ask questions at the end of this session. So if we can pull up the first one.
My name is Junaid Razak. I'm an emergency physician. I have experience of working as a clinician in the US and in Pakistan and a few other countries. So thank you for the invitation. Questions are so much fun. So in return for one question, I'm going to pose 3 questions. Well, they may raise some possibility of answers. But let's talk about the right questions first. My first question is, what is the surgical ecosystem? And for me, it is an unbroken, easy to navigate chain of survival. And we often use the term chain of survival for cardiac arrest and for major trauma. But here I'm talking about an easy to navigate chain that is able to provide good outcomes for patients with acute or chronic illnesses. And the second definition I have is unbroken chain of care with dignity. For me, surgical ecosystem is an overly complex, overly medicalized system. Let's demedicalize it. Let's despecialize it as much as possible, of course. What happens in the communities, what happens on the roads, on the streets and homes have direct impact and relevance to surgical ecosystem. My second question is, do we all share the same definition of success? Do we have shared values and definitions within the medicalized, specialized surgical ecosystem? And do we share those values and successes with the users of the service? And as we start to share those definitions of values and successes, we start looking at the whole person, and we start speaking the language that matters, the language that people understand. And we want to understand where people are coming from instead of telling them what needs to be done. So that was the second question. Do we share the same definitions of success? The third question is, who is responsible for the health of the patients? Are patients alone responsible for the failures and success of their health? And as we all know, over the past few years, especially in the last year or so, there's been a lot of discussion around healthcare individual responsibility versus societal support. And it's become a politically dividing issue. Do sick, poor, elderly, mentally ill truly have free will? Are they really clients? Let's not judge people because they're sick, physically or mentally. Let's, as society, share that responsibility for the health of the most vulnerable in our society. And let's not overly judge and blame the patient for the outcome. Thank you so much.
Hello, I am Professor Sushma Sagar. I am professor at the Division of Trauma Surgery and Critical Care at All India Institute of Medical Sciences, New Delhi, India. It's a level 1 trauma center of the country. Now, first of all, I would like to thank the organizing committee for giving me this opportunity to interact with you all. When we talk about the improvement in the relationship of a patient with their own health by us as a part of surgical ecosystem, the first thing which comes to my mind is the way or by the method by which we can communicate to these patients about the gravity and the facilities which are available to them for their surgical illnesses. See, many a times people are not aware that these are the illnesses or these are the diseases which can only be corrected by surgical interventions. Like in obstetrics, we know that it is not only that all childbirth can occur by a natural course. So at times you need to have to undergo a cesarean section to save the mother and save the child. So similarly, that kind of awareness is required. Second thing, which is very much important, is the access to this affordable healthcare need. People, especially in our countries, are still not have an access to a nearby or to an affordable healthcare facility. In our trauma center, we have a policy wherein all the patients who come in first 24 hours of their injury are provided healthcare facility free of cost. And that has made a very strong and I would say a very favorable outcome to these patients. So similar kind of a model has to be adapted at a national level, wherein the surgical interventions which are required for life-saving, limb-threatening, or for the healthcare delivery should be made free of cost to them, so that we can cut down on their out-of-pocket expenses. And then the task of building a good trained manpower, skilled manpower, which are available at these nearby facilities. All this can be, in my opinion, can be achieved when we make it as a part of our national health mission. We have a very strong immunization program in our country, and at the same time, for the pregnant mother also, we have a very good, successful model when all the pregnant women are taken to the nearby hospital by the government ambulances, and so that they can deliver baby in a safe and clean environment. So similarly, if we can create the need of this surgical ecosystem as a part of our national health mission, probably we can achieve our goal in a much faster or in a much better manner. So we'll have more discussions later on. Thank you.
Hello, everyone. My name is Joanna Kocher. I'm a surgical nurse and a consultant in medical and surgical programming. I've worked in humanitarian aid for over 21 years in complex emergencies and armed conflict. In my usual role, I create, manage, and coordinate surgical programs in the field while mentoring and training our surgical staff. In this short presentation, I want to talk about the value of trust in assisting patients to take part in their own healthcare. My reference point is the patient within a community of internally displaced persons in a complex emergency. Even though this is an extreme example, it demonstrates the tensions that patients experience as they try to negotiate needing and wanting care and then acting on it. First, there are trust in the services. Now, we know that there is some element of fear and mistrust of medical and surgical services in most cultures. In our IDP scenario, this mistrust is fueled by violence in the environment, competition for the means of survival, and by rumors in the community, which are always present in a conflict. Trust in us and our services should never be taken for granted. It must be earned and nurtured with honesty and transparency. We must be visible to the community, and they should hear from us through our community health workers and our relationships and behavior within the community itself. This is really important. Patients also need to trust what we say. We're a link between the patient's medical needs and his or her ability to act on those needs. The question we have to ask ourselves when we provide care is, how believable am I to this patient? If I'm not believable, why not? How will I know that my patient believes me? The patient who is in doubt of the truth as presented by the team may not return for surgery, or when they do, are more likely to have ignored advice. This is the patient that will arrive for surgery having eaten a full meal without telling the anesthetist, or the trauma patient that is discharged with a full course of antibiotics only to pass them on to a family member, or worse, sell them in the market. Trust in the equity of care is very, very important in armed conflict. Patients need to know they have the same opportunity to receive surgical care as others in the community. Our IDP patient has many real barriers to accessing surgical services. These include threats to their safety, gender constraints, and security risks. Patients who believe that they will not be treated because of their ethnicity, their place of residence, such as a particular camp, or their ability to pay, are much less likely to engage in their health care in light of all the other barriers they face. We frequently see this in the field by the absence of specific groups among those that seek care. And this is proven through discussions between community health workers and the people themselves. I hope this brief scenario has highlighted the importance of trust between patients, their own health, and those who care for them. Thank you very much.
Hello everyone, my name is Lawan Ayedu Olubumi, a pediatric nurse from Nigeria, the CEO of Spinal Bifida and Hydrocephalus Care Foundation. As we all know, that 2021 has been declared as the year of the health and care workers. On this premise, I would like to discuss quickly surgical ecosystem and how we improve the patient relationship with their own health. First of all, a surgical ecosystem has been described as the network of people, processes, and material necessary for surgical services in the context of the facility and environment. And I want to say quickly that whenever patients are booked for surgical intervention, surgical procedure, such patients, either big or small, either women or male, they will come oftentimes with a lot of anxiety, with a lot of fear. Some are depressed, some are confused, fear of the unknown. They are not sure of the outcome of the procedure. And as a nurse who receive this patient, who admit this patient, who stay with this patient 24 hours, it is my responsibility to give what I call compassionate nursing care. With continuous compassionate nursing care, that will help to allay anxiety, to build confidence on this patient, for this patient to know that yes, the team actually care and we are there to safeguard the health of our patient. And secondly, the environment at which we nurse this patient matters. As a pediatric nurse, I will ensure a conducive environment, an environment, an environment without distraction, with a lot of support, with a lot of love. I will also want to give psychosocial counseling. I will also want to give a support that will help the patient to verbalize his or her concern. With all of this love and respect, I believe strongly that the relationship and the way the patient take the surgery will be different. And we use that information with the environment, with the experiences, that will help the patient to respond positively to the surgical services and to all care that we render for this patient. Thank you.
Hello, my name is Quentin Eichbaum, and I'm Professor of Pathology at Vanderbilt University School of Medicine. And what I want to talk about in this session on the surgical ecosystem is pathology as the missing link in global health. And I'll start off by referring to a book by Chris Murray, the very well-known book, The Global Burden of Disease, in which he says it is difficult to deliver effective and high-quality care to patients without knowing their diagnosis. To pathologists, that seems obvious, but it may not be obvious to everybody. Up to 70% of diagnoses from some publications depend on a pathology test, whether that's a tissue diagnosis or a clinical lab liquid test. And what I want to show in this talk of 3 minutes, or just 4 points I'll make to substantiate that argument. First of all, we need to realize that pathology is comprised of an array of subdisciplines and testing phases, all of which are aimed to achieve accurate, quality-assured diagnosis. First of all, there's clinical pathology, which is comprised of this incredible array of subdisciplines. Likewise, pathology has these subdisciplines, plus all the organ subdisciplines. And then, as I'll mention, laboratory technology, which exists in both of these subdisciplines, is critical to the whole endeavor. We also need to realize that we have in pathology testing pre-analytical phase, analytical phase, and post-analytical. And this is test selection, standardization, sensitivity, specificity, reporting, and interpretation. All very important to achieve accurate diagnosis. Point number 2 is that pathology goes beyond just immediate diagnosis of the disease. And that's not just the right diagnosis for the right patient at the right time, but it also involves disease staging and prognosis, monitoring and clinical response to treatment, disease surveillance, quality assurance, etc., etc. Point number 3 refers to the critical importance of the diagnostic pathology labs. And this brings to the front that it's not only clinical and anatomical pathology, but also medical technology. And without quality assured labs, you will get inaccurate diagnosis and incorrect treatments. So it is critically important that the laboratories be functioning with medical technologists very efficiently, or you'll have the vicious cycle. If you don't have good quality tests and underpaid and undertrained staff, you'll land up with presumptive diagnosis, as the World Bank study showed, and clinicians will lose confidence in lab services and resort to presumptive diagnosis rather than lab information. Presumptive diagnosis where you just think you know what it is and you treat accordingly. And that is very wasteful. The 4th point is that pathology in low and middle resource settings is comprised of an array of different settings, from very low resource settings to very high, and that necessitates the need for tiered testing, as the Lancet document pointed out, from tier 1 to tier 4, rural hospital, district hospital, regional, and national teaching hospitals. The testing has to be appropriate for each level of those four tiers. So those are the 4 very brief points I want to make in this regard, and that is, thank you very much for your attention.
Hello, I'm Keith Miles, the Executive Director and founder of Safe Surgery Initiative, a U.S.-based nonprofit organization that provides on-site surgical instrument, biomedical equipment refurbishment, sterilization capacity building, and education to medical facilities in low and middle income countries. We strengthen local surgical care services to increase access to essential surgery that could prevent 1.5 million deaths per year. I've been training technicians in surgical instrument maintenance for the past 15 years. In that time, I've come to realize the importance of advocating for patient safety in global surgery. So when asked to speak at the GS Satellite session, I thought about how, as a surgical instrument specialist, can I improve a patient's relationship with their own health? Being a member of the surgical ecosystem that doesn't have a direct contact with the patient, but has a direct impact on the surgical outcomes from a technical perspective. From our perspective, improving a patient's relationship with their own health means addressing the inequalities in the OR ecosystem. Typically, the top-down approach, from surgeon to nurse, leaves little room for input on improving surgical outcomes for those not in the OR room. Biomedical engineers, sterile processing technicians, whose job responsibilities play a major role in patient safety, are rarely involved in the decision-making process on improving surgical outcomes. How can we work together to address the lack of communication between stakeholders in surgical services? Our training in low to middle income country hospitals empowers OR nurses and CSSD technicians to voice their opinions in regard to proper process and use of surgical instruments and devices. Ensuring safe surgical instruments enter the OR theater is one of the many steps to improving a patient's relationship with their own health by having a positive outcome when they receive care. If surgical care providers have safe, functional surgical tools, they can focus on building a more cooperative relationship between the patient and the healthcare provider. Thank you.
My name is Susanna Cohen, and I'm a practicing nurse midwife and associate clinical professor at the University of Utah College of Nursing. I am also the founder of the LIFT Simulation Design Lab and a co-founder of Pronto International. As a midwife who's worked with providers around the globe in reflecting on the surgical ecosystem, one particular surgery obviously comes to mind, the cesarean section. The most commonly performed surgery around the world, and one for which the right amount is difficult to figure out. The percentage of births by cesarean vary widely between countries and within countries, from an obviously too low of 3 to 5% to a shockingly high rates of 50, 80, and maybe even 90%. We know that these rates are influenced by many factors and clinical training matters. Pronto International's simulation and team training in obstetric and neonatal emergency care has been studied in over 14 countries, mostly in low and very low resource settings. In order to do this work, we created the Parto Pants, a hybrid birth simulator in which the patient actress wears the pants and provider teams work together to manage obstetric and neonatal complications at the time of birth. We have studied our program in various implementation trials around the world. In Kenya, we found a 30% decrease in the perinatal mortality, a 37% reduction in cases referred outside the facility, and a 7-fold increase in the number of women who had birth companions. In Mexico, we found a decrease in cesarean section rates by 17% at 4 months, 24% at 8 months, and 21% at 12 months in the intervention facilities. And in Ghana, we found an increase in the patient perception of respectful care in the trained facilities. What about this training changes patient and provider outcomes? The obvious answer would be that practice makes better. A more subtle answer, and one that directly impacts the patient experience and engagement in care, is that our hybrid simulator requires a patient actress, someone to play the role of the patient, someone to ask questions, someone to cry out, someone to seize. I believe that is the use of the healthcare provider in the role of the patient that has the potential to develop deeply rooted clinical empathy and improve patient engagement by creating providers who truly understand the impact of respect, curiosity, and compassion. This is a nurse. She played the patient actress in our simulation, and she's having a simulated eclamptic seizure. What does this experience feel like in her facility? Did she feel alone? What did she wish her colleagues had done for her or to her? How about this delivery in Mexico? What was it like to have the baby taken to the corner and not to know what was happening if she was okay? And in Kenya, what did the nurse playing the actress feel when her colleagues shared her joy? In the debrief after the simulation, the patient in this scenario stated that she felt scared and overwhelmed, and the provider playing the support person cried. What does this experience do for her colleagues and for them when they the next time go to transfer a woman who's bleeding after birth? And now we all face an even bigger challenge. How can we be empathetic with layers and layers of PPE and worry for own personal safety during a pandemic? We are studying how the experience of playing the patient can influence the provider behavior in a real clinical emergency. Is it team-based simulation the key to developing clinical empathy? When we think of the millions of women around the world that are now facing the question of, is a cesarean section right for me? Is a provider who's experienced what it's like to be a patient better equipped to guide patients in this decision in an ethical way about the mode of delivery? I encourage us all to have this experience. Thank you very much.
Hello, my name is Ahmad Raza Abbaslu and I'm a 5th year medical student at Tehran University of Medical Sciences. Making change in behaviors of patients has many factors. One of them is education, which means how we can increase the awareness in our patients. The other part is making them feel valued. You know, we know many people who knows about the harms of cigarette and smoking, but they do not have any intention in changing their behavior. That's because of they're not feeling valued enough to change their own behavior, or they're not feeling enough motivated. If you want to make people and patients to care about their own health, we should know that we should follow these 2 steps. But how we can help them, how trainees and students can help them. We know that the students and trainees are the people in the healthcare system who have the most exposure with the patients. So they're a great medium for transferring data and information to the patients. So we should use this opportunity as a way to increase the awareness of patients. But there is a thing. As I know, not only in my hospital, but in other hospitals that I've spoken with their students or trainees, most of the exposure is about the treatment procedure, asking the history taking, and for, putting orders. It's not about, making trust and convincing people to change their own ideology, their attitude. So we should consider this responsibility as a defined role for the students and trainees. That's how we can make this a sustainable change in the system. But we should consider that students and trainees have a limited capacity of workflow. They have lots of things to do in the hospital. And the system should help them and reduce other responsibilities, decrease other responsibilities to make them able to take this new responsibility. Thank you.
Dear colleagues, my name is Andre Algawi, and I'm the focal person for cancer at the World Health Organization. I'm a surgical oncologist by background. May I begin by thanking Dr. DeVries, Dr. Swaroop, and the organizing committee for the invitation and for raising the important principle of empowering communities. As surgeons and health professionals in the surgical ecosystem, our highest priority is the patient in front of us today, the patients we care for. And once we operate on a patient, that person is now part of our panel, part of our community, someone for whom we will care as concerns arise throughout their lifetime. But that is the patient of today. There is also the patient of tomorrow. Tomorrow, we will care for a 53-year-old woman who will present with advanced stage breast cancer simply because she did not have access to a screening program or to a primary care network. We will care for a 75-year-old male with prostate cancer who had to sell his home simply because he cannot afford the direct or the indirect costs of cancer care. We will care for a child who will be receiving substandard chemotherapy because quality was not assured along the supply chain. The patient of tomorrow is also a patient we care for, and that patient is also part of our ecosystem. And as surgeons, we are also leaders. We have changed legislative policies, we've driven innovation, we've moved mountains. So what can we do to improve the health system to support patients of yesterday, today, and tomorrow? We can speak with our patients, ask them, how is the healthcare system meeting their needs? Perhaps it is to make treatment more affordable, to change the opening hours for a clinic, or to open a new clinic closer to their homes. One of the greatest achievements we can make in the surgical ecosystem is to ensure that our health systems meet the needs of our communities, are more integrated and person-centered. At WHO, we stand ready to support governments achieve this goal. And we thank the health professionals that enable health systems to function around the world, the health professionals that have been at the front line during this pandemic and for the millennium that have passed. We serve our patients together. We look forward to working together to build this ecosystem to support global surgical patients, wherever that they may be. Thank you.
My name is Salma Narain, and I'm an interventional cardiologist at the University of Texas here in Houston, Texas. In my journey to becoming an interventional cardiologist, I've had the opportunity to train in and work in different health systems across the world. Much of my training has been here in the US, but ever since becoming a cardiologist, I've had the opportunity to work in underserved communities, both here in the US and overseas, including Pakistan and parts of the Middle East. I've also participated in cases in places such as Japan and Germany, and this gives me some perspective of what the surgical ecosystem entails. So the question before us is, how can I, or us, as part of the surgical ecosystem, improve our patients' relationships to their own health? And I think this is a faceted question, if you will, and everyone will bring their own perspective. I personally think my approach would be to redefine the patient's relationship with their own health and redefine how the patient sees him or herself within this ecosystem. I think the first step would be to help the patient understand that they are one of the major stakeholders and that this is meant to be a two-way communication between the patients and their healthcare providers. I find that patients, particularly those in underserved communities, are often very grateful for the care that they receive, but they're also less likely to participate in an active fashion, often taking the physician's recommendations without having or engaging in dialogue. I think one important aspect of this would be to have the patient see the interconnectedness of personal behaviors and lifestyle choices with their health. Many patients become sicker before they realizes that the illness perhaps stems from habits that they've had for many, many years and which they thought were perhaps normal because they saw their parents or their neighbors do those. Once we have patients who are aware of healthy versus unhealthy lifestyles, we can then identify the good ones, the habits that actually both prevent disease and perhaps are curative or can help manage disease. I feel that while in our communities, many times as proceduralists, our treatments are often surgical or interventional. There's a lot that can be done in terms of medical therapies, which patients are often unaware of. Once you've established a framework of healthy lifestyle that is unique to the patient's own society and community, we can then sort of help the patient or engage the patients and their families to come up with perhaps a template for what a healthy lifestyle should look like. And the whole idea behind this process is to create what I think would be a health ambassador, not someone who comes from overseas or perhaps from another community, but someone that's homegrown from within that community, a health ambassador who can then speak the language of the patients and help them understand.
How can I, as a part of the surgical ecosystem, improve patients' relationship with their own health? Is a question that it is taking me back to August 1998, when we have done the first mission in Rabat, and it was a great system where we have been helping more than 150, but at the beginning when we have started, we were uncertain that we are going to reach such objective. Now that we are having our 21 years back of us, we have been helped more than 12,000 patients all over Morocco with the dedication and help of all our volunteers. We have managed to improve our patients' relationship with their own health by being very close to them, going to their own region, helping them where they are. And once we have finished with the cleft surgery, thanks to our volunteers, surgeons, we have decided to complete the care and complete the comprehensive cleft care. And this is how we can reach it by creating centers. The first center was created in 2008, and it is in Casablanca. So we have seen that the outcome is fabulous, and the results are just what it should be done in the domain of the cleft care. Then we have decided to create other centers to be even closer to our patients. We have opened the second one, the third one, and the fourth one is coming on Marrakesh, in order to close the circle and take care of all the patients in every single region. I think that this is what we call a relationship of the patient with their own health. If you have a commitment, you should go to them and see what are their needs and help them where they are. Thanks to our doctors in all fields, from the surgeons, the anesthesia, the dentists, the orthodontists, the pediatricians, and our nurses, we have been able to fulfill our commitment and give really good results of care in our comprehensive cleft care centers. And we are looking forward to do even more in the future. Thanks to our volunteers in all fields, we have been able to reach all those fantastic results. Thank you. Thank you for listening.
Hello. Well, those were amazing videos, and we have all of our presenters on the videos as panelists, and we'd like you to think about the questions you'd like to ask them. But I would like to just think about a few things that were brought up in the discussion, and the biggest point, I think, is trust. All of the panelists hit on this issue, and I think it's a really important one for us to consider, especially in this year where COVID has pointed out that communities really have some big problems with trust in healthcare. In fact, even in this morning's news, I was hearing that there are legislators who are proposing legislation to override the recommendations of the public health people and the science behind our basic public health. Now, if that is an issue, and if trust can be legislated, and not just in communities, but in national forums, then we have some real work to do throughout our whole healthcare system to manage and to support that trust. One thing that's happened in surgery is that we expect patients to come to us. And I think in the last video, you saw that there is a strong case to be made to go out to patients. But it's also true that we are really busy people, and we hardly have time to eat lunch sometimes for all of the patients. If you look at busy clinics, they're lined outside and sometimes around the corner, people who really need and want care. So how do we bridge this gap between trust and the needs and the time we have to allocate? You know, as a surgical community, we have not been very good advocates, I would say, and maybe we need to start learning how to reach out and voicing our thoughts in more public ways. I think we have a lot of wisdom within our panelists, and I'd like to ask my co-moderators, Eric Etchell and Yajur, to now, Yajur Maker, to now start with the questions and answers, and please share yours for the remainder of this session one.
Great, thank you so much, Dr. DeVries. And as Dr. DeVries mentioned, we have some amazing panelists here today, and just like to remind everyone that while we'd love to listen and learn from your life lessons to make sure that everyone has time to answer questions, please try to keep your responses to 1 to 2 minutes if possible. Dr. Razak, I'd love to start with you. Thank you so much for helping us to understand and analyze what is truly meant by creating an effective surgical ecosystem, defining success in the system, and questioning where the burden of success lies. You mentioned that there's a direct connection between what happens in communities and in patients' homes and the surgical ecosystem. How can we all, as healthcare providers, researchers, students, and global health advocates begin to better make this connection to improve the patient-healthcare relationship?
Yeah, thank you, Ajur, and thanks everyone on the organizing committee for this opportunity. I think I would like to share 3 quick points. First, perspective is everything. And as an emergency physician, if I see my patients as those who are in my emergency department, versus, and this is what I feel most comfortable with because this is where I live professionally, versus my domain as where a patient with an emergency is. So it could be anywhere in the community. So is the patient in the OR or in the hospital my patient, or is the patient with surgical disease, no matter where they are, that is my patient. So I think that perspective of defining our specialties based on the patient and not where we are is important. Second point, we all talked about engaging communities. I think, and we're all very busy, it's very hard to get into the community. If there was a mechanism that the community can be brought into some of our activities, and it's a little bit of a risky game bringing people in what we do, but I think they having that more formal defined engagement so that they are an advisor, they are our guide in how we do things is important. And my final point is, as part of our training in the medical school and subsequently having that focus on community-based training, a couple of weeks in 5 years, we can all afford to get those time out, and getting the exposure of what's happening outside will be very important. Thank you so much.
Thank you, Dr. Razak.
Thank you. Next, we'll move on and ask a question for Dr. Sagar. As a professor in trauma surgery in New Delhi, you highlight in your talk a key policy at your institution that has significantly reduced out-of-pocket expenses for patients who receive care within the first 24 hours of your visits. This parallels in the US the Emergency Medical Treatment and Labor Act, EMTALA, which is a federal law that requires anyone coming to the emergency room to be stabilized and treated regardless of insurance or ability to pay. Question for you, as you work to try to nationalize free of cost emergency and trauma care, what steps can be taken to ensure access and funding of such a policy?
Yeah, thank you, Eric, for a wonderful question and very relevant and very pertinent to today's discussion. As we have heard from all the panelists, that it is actually the access to the affordable healthcare which is so very important. And when it comes to, especially for my specialty, for the trauma care, wherein time is of essence and time doesn't see the availability of money or resources. So the best thing is that whatever resources are available, they are made available to the person who's injured, who's victimized at that point of time, who may come to your hospital as an unknown person, as a person who has nobody to take care of. And at that point of time, asking money from that person or delaying the healthcare facility to that person because of lack of finances is totally unpardonable. So that kind of system is required, wherein that should not be a cause of concern for the person to seek for the financial help. And that's why this model was adopted at our trauma center, and in other parts of the country, the same model is also being used for the pregnant women. Now, the question is that how the government is going to support, or how the government is support so much of people. Like we have 1.3 billion population, so it is difficult to bring in so much of resources for them. And the best model or the best solution which in the current scenario I can think of is the money we are collecting through the Motor Vehicle Act. We have a very stringent Motor Vehicle Act in our country, and every day the traffic policemen are collecting a lot of money from them due to violation of traffic laws. So that money can be used for the emergency care, for providing free of cost emergency care. And second thing is, like, I saw a model in Australia, Alfred Hospital, wherein they told us that when a person goes to buy a vehicle, whether it is a two-wheeler or a four-wheeler, they have to pay a certain amount of money for the healthcare facility. So if we can attach that deposition of money when a person is buying either a vehicle or is buying gadgets like helmets, they can deposit that money, and that money the government can use for the provision of providing the free health care. So I think apart from awareness and access, the healthcare needs to be affordable, definitely. Thank you.
Fantastic. Thank you.
Great. So my next question is from Ms. Kocher. Your key word while discussing how to improve the patient-healthcare relationship is trust. And you highlighted many examples where building trust can be crucial to ensuring effective and equal access to care in global health settings. How often have you found that there's mistrust between patients and their healthcare providers? And what steps can we or you have taken through your humanitarian work to build trust in such scenarios?
Right. That's an important question. And what I would like to do is break that down into three pieces: prevention, response, and the behavior. Okay, so we try to prevent problems of trust in the community by um, really very close to the field, close to the ground actions. For example, guns in the hospital, guns around the hospital. And in an armed conflict situation, anywhere you have weapons, there's a potential for mistrust. And I know this is far away from the technicalities of surgery, and don't I know all about the technicians and the technology of surgery and how we lean on it. But my view is much closer to reality in that field hospital or in that referral hospital. So prevention, number one, also can be taken. We can undertake prevention by inviting the community to the facility, not when there's been a bombing, not when there's a patient that needs a C-section, but when we open, we invite the community in. Um, we scrub everything down after they've gone, and we start our work. But before we actually start, we do invite the community in, and I think this is really an important step. The other thing in prevention is to make sure that we don't have any kind of graft or favors or any other type of corruption within our own facility. And I can tell you that I have never been in a facility where this didn't have to, where this didn't occur. There's always some bit of favors being done, resources being put aside for this or that when they should be going to the patients, and we have to deal with this preemptively. And the other part of preparation is to have somebody on staff that has a really um, good reputation in the community and a good feel of the community, to just keep an eye on what's going on in the community, to have an ear out, listen up to what the community is saying about our doctors, about our nurses, about whether we respect the cultural things that bind all the community together. And this is important, that you have to be constantly vigilant in order to stop it when it happens. Um, so I think that was, I hope I didn't go over, but that's the basis of it. It's much more complex than that, but that at least gives a feel for how we manage it.
No worries. Thanks for breaking down that three-step solution.
The next question will be for Ms. Olbunmi. Continuing with the theme of trust, as a pediatric nurse, you highlight compassionate care and creating a supportive environment as two key factors in improving the patient and healthcare relationship. But as we all know all too well, in low resource settings where time and resources are heavily limited, it's often difficult to put in the extra effort to provide compassionate care or create a nurturing environment that's so vital for trust. How have you worked with your healthcare teams to overcome this challenge?
Yeah, thank you very much, Eric, for that wonderful question. And thank you for inviting me. I want to say that, like I keep saying, that talk is cheap. Many people as leader, we talk and talk and talk, but we don't do what we talk. So as a pediatric nurse, as a leader, I've been a pediatric nurse for 15 years now, and a nurse midwife for more than 25 years. So oftentimes, I understand the environment that I work in Nigeria, and just like in any other LMICs, where there's a lot of workplace burnout, where there's a lot of emotional exhaustion, where there's a lot of depression, where there's a whole lot of distraction in the healthcare system, where we have high rates of what I call unnecessary rivalry. But one thing I do is the fact that what is the reason why we are there? The patient is the ultimate. And that is the reason why my goal to save life really influenced my action and my passion. And most of my colleagues and the team, as a pediatric nurse, in all the departments in the hospital, I think pediatric departments are more homing. We work together like a family, and that is what we know, and that is what we do. So the commitment to saving life of a baby, of a newborn, can you imagine having to carry this baby for 9 months? At the end of the day, the baby come out with gastrocases, which was not diagnosed in utero. Is devastating. And the only thing we can do is to help this mom, support this mom. And oftentimes, because of the number of patients, you can imagine working alone as a nurse to take care of 30 patients, working alone as a nurse to take care of 35 patients. But that does not mean that I won't do my best because of the passion to save life. And that is why I feel that in all of this, compassionate care is key. And it does not matter if you are a nurse, it does not matter if you are a surgeon. You can imagine having a compassionate care as a surgeon. Your patient will look at you as God. So which means that you need to respect your patient, you need to communicate with them, you need to listen. And of course, the space of capacity building is also key. And finally, I want to say that even in our curriculum as nurses, our curriculum as in medical school should have the components of compassionate care. And that is what I preach. Capacity building and living a model approach is the way to go. Thank you, and over.
Thank you. That's really a wonderful answer. And I think it's obvious to everybody that your patients are really lucky to have you. So thank you.
Hi, so my next question is for Dr. Eichenbaum. As a pathologist, you've made a strong case for pathology as the missing link in global health and discussed a tiered approach to testing and capacitation to avoid presumptive diagnoses from being made at all resource levels in the surgical and global health ecosystem. In practice, how can we ensure that effective testing be made available at the rural or primary care setting in LMICs? Dr. Eichenbaum, I think you're muted.
Apologies. There we go. Now I'm off. Can you hear me? So this approach was intensively studied and proposed by a number of people and eventually published in a Lancet document on pathology in low and middle income settings where 4 tiers were proposed. It's challenging. They laid it out what kind of testing should go in tier 1, tier 2, tier 3, and tier 4, which kinds of resources should go in each tier, and it was mapped out quite carefully. I think your point is well taken, and I have some differences of opinion about what goes in which particular setting, but the broad strokes are relevant. And I think from that perspective, one should map out quite clearly. You can't do everything everywhere. I mean, we have well over 3,000 tests in pathology. People don't know, so obviously can't do it everywhere. You have to decide what is most appropriate to do in a simple rural clinic where you don't keep patients overnight. What do you do in a district hospital? What do you do? And so from that perspective, the contexts are vastly different as well in different countries. So I think countries should, carefully think about it and decide what they have and what they can appropriately implement in different settings. I did just want to point out, and I had wanted to show in my talk, the incredible shortage of pathologists in the world today. In Africa alone, there's a shortfall of 27,000 pathologists, which would take at current rates of capacitation 450 years to fill, up to Western standards. Some countries have no pathologists, 0. Some have 1 or 2. How on earth can you diagnose and treat in those settings? So the problem is, it's almost, some countries have nothing. You can almost not diagnose effectively. Someone's doing the diagnosis in the lab, but we need people who can put those lab tests together and provide effective diagnosis for effective treatment. And that is a critical part of the surgical ecosystem. So I hope that answers part of your question.
Absolutely. Thank you.
Thank you. The next question is for Mr. Miles. You bring a unique perspective to improving the patient-healthcare relationship as the Executive Director of the Safe Surgery Initiative. Could you please share a particular example of a time when involvement of biomedical engineers or sterile processing technicians has helped your nonprofit to improve the patient-healthcare relationship?
Hello, Eric. Thank you for having me.
Sure.
I thank the panelists and everyone for setting this great opportunity up for us to discuss patient safety and their relationship with their own health. One of the particular examples that always comes to mind in regards a situation in Nigeria when one of our biomed engineers we trained was called into the OR theater as the case was about to start. The patient was on the table and the dial-therapy machine was malfunctioning and they couldn't proceed with the case. So since they didn't have any replacements available, they needed a biotech to come into the OR theater to run diagnostics and repairs. So as you can imagine, by this time the OR frustration levels is rising. And by the time the biomed techs arrive, the blame game is on full effect. The surgeons are complaining, the nurses are complaining, the staff, it's just it creates a very, stressful environment when most of the focus should be on the patient care. So the technician comes in, he quickly assesses the situation and begins to run diagnostics, finds the fault, and is able to get the case resumed. But while he's doing that, he's having conversations with the staff, placing some well-timed jokes and really trying to ease that tension that he's felt coming into it because he's been in this situation before. So we really kind of think about how, from a technical perspective, how equipment, surgical equipment in particular, is so important to a patient's safety and for a patient's outlook on their own health. It's very frustrating when surgical devices don't function properly during the procedure and puts the patient at risk. Surgeon gets upset when a nurse hands them a dull scissor and then asks for another one and they receive another dull scissor. And the nurse is upset because she knows that all of the instruments are dull and that they're gonna have to repeat this process tomorrow. The frustration builds up in the OR room, and then a lot of times, once the case is over, instead of making adjustments of purchasing new equipment or coming up with some type of maintenance program, they consider it just as a status quo and move on and repeat that same process again. So we think about, nurse anxiety and how that affects patient outcomes. And this situation is more the norm than exception when it comes to surgical providers in low resource settings. So from our perspective, working in low resource settings, positive surgical outcomes will improve the patient's relationship with their own health and by extension, others in the community. The incidence of patients seeking surgical care and leaving the hospital paralyzed or for other unforeseen results has a detrimental effect on how they view healthcare providers. Too often the fear of surgery prevents patients from seeking care or medical intervention. So we think that if we can increase the positive outcomes, it's more likely that patients will trust their healthcare providers. And because without that trust, then we run the risk of mislabeling patients as non-compliant or difficult because they have all of these horror stories from previous, relatives, people in their community where, someone went into surgery for back pain and now they can't walk anymore. And that could be, a myriad reasons why that happened. But from our perspective, we try to make sure that from a technical standpoint, that we're addressing the issues relating to surgical instruments, surgical maintenance devices, diagnostic machine, anesthesia machines, making sure that they're functioning properly to improve those odds of good surgical outcomes. And we can increase positive outcomes by ensuring the technical apparatus or OR rooms are fully functional. We can make systemic change in communities and improve a patient's relationship with their own healthcare. Thank you.
Absolutely, absolutely. Thank you for that wonderful answer, and thank you for your work and your role as such an essential part of the ecosystem that is often overlooked. Much appreciated.
Thank you.
Great. So Dr. Cohen, I have a question for you. Through your work with Pronto International and the development of the Parto Pants, you've helped to turn a unique and low-cost training solution into an impactful innovation. Whether in Kenya, Mexico, or in India, how did you establish these global partners in low-resource communities and effectively overcome boundaries to implementation of the Parto Pants?
Yeah, thank you for that question and for this opportunity. And I wanted to agree with all of my fellow panelists that the thinking about providers and communication, compassion, and confidence of their skills is utmost important in being able to create providers who can respond to patients' needs and desires. So I think that the big, why simulation? Because simulation really looks at how we can bring the humanity back to providers, meaning that we've kind of lost that in our educational systems. We're training for skills, but we're not necessarily training for humanity. And understanding that providers are people too, and they face enormous obstacles in giving care in really low resource settings. As we heard earlier, in terms of the patient load, the resources they have available to them, the human resources they have available to them, the surgical resources that can take a toll on the person. So when you do training, providing training that really elevates their humanity as well is going to allow them to be able to adapt new procedures and new evidence-based care. And really focusing on the fact that evidence-based care is the intersect between what we know from the evidence, what we know from our personal experience as providers, and what the patients want. And it's really the intersection of that and how allowing providers to do that. Our success has been really initiated by our in-country partners. So if somebody hears about us, then they can contact us and we can talk about our intervention. But what we find most successful is having firsthand experience. So if a program or a country has come to us, then we offer them the experience of the simulation. And then once they experience the simulation, we can all imagine together how the simulation may augment and elevate their existing programs. So it is like asset mapping. It's this idea of what is existing already and what's going well, and how can simulation elevate those elements, and also identify some gaps that could be solved by internal mechanisms. So our trainings are interprofessional, so everyone is on the same level. They're interactive and fun because we all need to have fun while we're learning, and they're really based on the actual resources in the facilities. So we go into a facility and we don't assume they have any resources that they don't already have. So interprofessional teams learn within their actual clinical settings and can learn to figure out how they might make changes. One example is in Guatemala, early on in our intervention, the team, delivered the simulated baby. The baby was not breathing. They brought the baby over to the plastic basin to do the resuscitation, and noticed very early on that they couldn't actually get into the right angle to provide appropriate positive pressure ventilation to the baby. And so the discussion that evolved after that is, what do we need that's different in order to resuscitate babies in this facility? And they sort of made some plans to do that. When we came back 3 months later, they had created a table out of wood and a heat source, and then they were more able to efficiently resuscitate that baby with the limited resources that they had. And they also felt stronger in their own powerful place of making change in their own systems. So really, it's about understanding and listening to your partners, and being flexible in your programming and adaptive to their own setting, and then allowing the solutions to come from within. And the simulation is a really wonderful way for folks to begin to look at, where are their gaps, what are we doing well that we could continue to do, and what could we do better, and how can we work together to do that.
Great, thank you for tying in your answer into our overarching theme of asset mapping.
Great. Next question is for Mr. Abasolu, which I think is really valuable to have a student perspective here. You discussed that one of the crucial steps to improve patient relationships with their own health is to educate them on the interconnectedness of their behaviors with health outcomes. And you advocate that students should serve as important liaisons of this education process. However, as you mentioned in your video, and as most of us know, it can often be difficult to empower patients to take action, even after effective health education. The question I have for you is, have you experienced this? And what advice do you have for those trying to address this issue of a disconnect between education, knowledge, and behavior, especially when resources and time are limited?
Thank you very much. And I should appreciate you all for making this opportunity for all the parts of the health sector to be present here, such as the students part. First of all, I want to say that I liked one of the questions we were asked in the Q&A box, which was saying that at the beginning of that we have found the elephant in the room. This problem, which is mentioned about the patient's relationship with their own health, is a kind of complex problems, and we know that complex problems require complex solutions. So if I suggest anything from my perspective, from students' perspective, it doesn't mean that, for example, that solution should be applied only on students. The solution should be applied on the entire system. The entire system should help students to be able to do the suggested solutions, for example. As you said, and as all the other panelists have said, one very important part of each change is trust. I do agree with you that we all have the experience of having patients that we have given them advice about their own health, and they do not follow any of them. And the part of that is, maybe they do not trust us, maybe they do not motivated enough, maybe they do not feel valued enough for making a change in their own behavior. So what is a student's role here? The role of a student is not a technical knowledge. It's kind of soft skill knowledge, which is about advocacy and negotiation. I always tell my juniors when they enter the university that you're studying lots of things and you're learning many things about medicine, but there's a thing that you do not learn from university and you should learn it by your own self, which is negotiation. It's not only for the politicians, it's for all the physicians in their own office. And how we can learn that? We can learn that by our own self. But I know the most important source of learning in any teaching hospital are professors. And it's not the a verbal source of learning. No, their act and their action is a kind of role model for all of the students, regardless of their generations. So I think that the most important part is the way that students can make trust for the patients, trust to the entire health system by what they have learned from their professors. Thank you.
Thank you. It's a very insightful and sophisticated answer. Thank you very much.
Hi, Dr. Obawi. I have a question for you now. You discussed key examples of how we can all help improve the patient-healthcare relationship, such as altering clinic hours, making treatment more affordable, or moving clinics closer to their homes. These efforts require changing infrastructure and the collaborative efforts of many individuals and partners, often with various motives and interests. At the WHO, how do you help to coordinate these efforts? And from your experience, are there any lessons learned that you can share with us today?
Yeah, thanks for such an important question. Fundamentally, as you rightly raise, change takes time. And I think going into a change process, we have to acknowledge, even when you look at the history of universal health coverage, that is ensuring that everyone can have access to care. If you look at European countries, it took decades. And so when we set expectations for ourselves and for our partners, change won't happen immediately, but it is something that starts with a small seed, and believing as a community that we can be that seed is really the most powerful message that all the panelists have spoken to. This for us is fundamentally what WHO can help offer, because for us as an organization, our greatest asset is at the country level. So WHO has over 150 country offices where we sit with partners and we sit with the ministry at the request of the government and make that change happen. And for us, the key lessons of multisectorality really do start with the principle of listening to each other, having everyone at the table from the beginning, and ensuring that each role and responsibility is appreciated, that everyone should have a voice. Just a few quick examples, recognizing that time is short. We see in countries like Peru or the Philippines, where a small community of advocates, in fact, pushed for new legislation that ensured that treatment for cancer care is available. We see people in sub-Saharan Africa change the way that providers are trained so that competencies are developed that are integrated in person centers. These things start again with people that believe that change is possible, but are respectful that in order to make that change happen, everyone needs to be at the table. Thank you, really. I think what you guys have done here is phenomenal. You do have everyone at the table. And for us in the surgical community, this is the beginning of what should be a transformative dialogue.
Thank you. We have about 2 minutes left, so I think we're going to hurry up to the final two questions for the sake of time. But Dr. Arain, as one of the final components to improving patient health in the global surgical ecosystem, you discussed creating a framework for a healthy lifestyle that comes from and is tailored to communities that patients live in. You also briefly discussed the role of a health ambassador. Expanding on this, how can we support patients to continue practicing healthy living once they leave the hospital?
You know, that was half the time for my answer to that question, but that's okay. No, I'll make it quick. So I think while it's the last topic that we've discussed, it's probably the first topic when it comes to patients. You know, all these differences between us as providers and them as patients tend to be somewhat artificial and convenient for the roles that we play. Ultimately, we all become patients too. And what's important to realize is that patients are, as someone pointed out, often scared, often don't know what's going on, and often very sort of dependent on their providers. So we just have to keep an open line of communication. And my own personal perspective would be to try and get to study the culture, see what the constraints are at home and cultural constraints, and then use people on the ground to create this understanding. And again, I think we can talk about this later in detail, but it all begins with understanding where the patient is coming from and having them go from there.
Absolutely. Thank you.
Thank you. So our last panelist, Ms. Mahmoudi, through your work in creating the Operation Smile ecosystem in Morocco, you highlight the power of reaching patients in their communities. Some of the greatest barriers in achieving this pillar of success in global surgery care is funding and community support. How have you been able to overcome these barriers as you continue to open more Operation Smile centers? And what advice do you have for organizations that do not have major donor or governmental support? Ms. Mahmoudi, I think you're muted.
Thank you for this question. I'm happy to share with you to have this opportunity to share with you how we have managed to overcome the barriers of funding and gain the community trust and support in Morocco in order to realize our planned objectives. When we have started in August 1998, we were not even officially established. Therefore, we worked side by side with our partner, Operation Smile International, to learn how we can treat efficiently those cases of cleft lip and cleft palate. And from there, we have also learned how to make first steps to make the fundraising. So we started with the organization of some gala dinners in which we have started to build up our funding for the organization locally. Then we have also started by building up the team of volunteers in Morocco. So we have been able to build up a team of hard workers, passionate people, that are enjoying the team spirit and committed towards their communities. And we have created also a deep synergy between the local and the international team of volunteers, and through some collaborations in missions outside and inside the country. The second point is our focus on the quality of care for the cleft lips and cleft palates. And this is starting from the age of 1 week, 2 weeks. We take care of the kids by placing the non-nasal alveolar modeling obturators for them as a part of the pre-surgical care. We don't have here in Morocco, we don't have even the feeding bottles for the cleft patients. So we started by importing them from the States and delivering them to the community. And we have started also by taking in charge those cleft patients for surgery at the age of 6 months, and then at the age of 12 months for the cleft palate. By doing a great work and great job in the quality of cleft lip and cleft palate, we have been able to build the trust for our donors, okay, and our corporate donors and the individuals. And we have built up also the trust from the Ministry of Health and the government. And we have been able to collect those fundings to be able to do our missions and to build up our centers in the 3 areas where we are now in Casablanca, Oujda, and El Jadida, and the next one is going to start maybe in 2022 in Marrakesh in order to cover the whole Morocco. We have also been able to go to the areas where our patients are. So we went from Casablanca to the north, to the south, and to the west, and to the east, in order to be very close to those patients. And this is also allowing us to be able to raise some funding in the same area where we are. So we are diversifying the ask from different places, not only in one place, not only because we are based in Casablanca, we are going to continue just approaching the people in Casablanca. If we are going to the south, we will go also to the people in the south, the donors in the south, to be able to raise some funding and to respond to the needs in that area.
Great.
All those care. Sorry.
Our time is a little bit
okay.
over here, so,
okay. Anyway.
Thank you so much for discussing the infrastructure that's so crucial to Operation Smile, and hopefully we can learn some lessons and expand that. I think we are into our coffee break time. Does Dr. Kathy or anyone else like to help us to transition?
I think we are going to take a quick break now for about 5 minutes before we have session 2 starting up. So if you need to take a bathroom break, walk around, stretch your legs, we will meet back in about 5 minutes for session 2.
Thank you so much. That was lovely. That was lovely.
Okay, I'm happy to see you face to face.
Yes, absolutely. Yes. Thank you, Quentin. That was lovely.
Thanks, everybody. This was a wonderful panel. I was really so happy to see you all in person, and I loved your videos. You know, that's a lot of work to put together a video, a short video, and to put so much information and also spirit. You know, all of them were so nicely animated by the passion you have for the work you do. And I think that was well received from the text messages that I've gotten from participants. I can tell they have really been engaged. And I think that this session went so well, thanks to you.
Yes, you guys made the session so wonderful with the videos. Yeah.
Thank you. Sorry, just one question. The short biography that we have sent, is it going to appear somewhere?
Yes, so it's in the program. You should have received the program last night. It was attached to the email with the links. So it's in there. Yeah. And that's been sent out.
Thank you.
That's been sent
I am
out
going
to everybody, and it will be posted as well.
Maybe we ought to make another mention of that, of the program, and refer people to it, because it did come out kind of late, and in the flurry of emails and texts and
I will post it at the
messages. That'd be a great thing.
Yeah.
I will be moving now the speakers of panel 1 to attendees. Thank you so much again for this wonderful session.
So Kathy, you will keep me up so I can introduce Rob Glasgow.
Absolutely.
And the other moderators.
Absolutely. I will keep you and Dr. Sorubop.
No coffee for us.
No. Hopefully your caffeine levels are sufficient at this point, Catherine. How are you?
I'm well, thank you. Thank you so much for joining us, Rob.
That was terrific. I had a finance meeting this morning and I got on this right as that ended. It's the exact medicine that I needed. It was fantastic.
Well, you know, it's so great to see people from all the different countries. You know, the people from every WHO region have joined us, and the students are fabulous. They've done a lot of the behind the scenes work. You know, the students and trainees of Incision have been heroic in doing all of the detail work behind all of this. So
very humbling.
Well, it sure is, because I don't know the technology, and I really hope I don't have to learn it. So we'll start in just about exactly a minute or so, and I'll introduce you.
Yeah, you just need to know how to work your answering machine, isn't that right? Isn't that the...
Yeah, and my remote.
Yes.
I've solved that by not having a TV anymore.
I know that works.
Good to see you, Dr. Anderson. How you doing?
How are you?
I'm doing well. Doing well.
So do we have everybody here, all the panelists for session 2?
We are missing a few. I am missing Dr. David Alexander, Dr. Misk, Dr. Jacobson, and Dr. Ribeiro. If they are in the attendees, please raise your hand. I am searching for you.
I believe I saw Dr. Misk earlier.
Yes, Dr. Misk was here earlier. I thought I saw Dr. Alexander briefly as well. And there's Dr. Annette Jacobson. Do we have Dr. Jimenez?
I was here earlier. I'm also missing her.
And do we have Dr. Ribeiro?
We have 4 minutes to the start of the session, I believe. So if you can reach them.
I think it's a wonder that we've been able to get as many people with all the time zone changes.
Yeah. And reliance on the internet.
Yeah, it's remarkable. My own internet is dependent on the weather. So if the towers go down, we're toast.
You know, we're getting Google Fiber, but just the receptacle that they put in your front yard cost me $250 in sprinkler damage. So I'm a little concerned about bringing the cable up to the house.
Yeah. Well, we have Wi-Fi from a tower, which is a couple of miles away. So
that's good.
It'll be a while before we get any kind of fiber. Yeah. Enron actually did bring a fiber all the way past our place, but then when Enron went belly up, the fiber sits there unused for years. I think we might just get started. Is that all right?
Yes.
Well, then I would like to welcome everybody back from a break and begin session 2, which has special interest for me. It's about value, and it's about what we understand as value. And we believe that there may be some different interpretations of what is valuable and what is valued in the surgical ecosystem. And we've invited a wonderful panel and moderators with expertise in value as a defined thing. So I'd like to introduce Dr. Robert Glasgow. He is the acting chairman of surgery at my own institution. Dr. Robert Glasgow is professor and interim chair, as well as chief value officer for the Department of Surgery at the University of Utah. His research and administrative interests are in the area of optimization of surgical quality and value. Dr. Glasgow oversees the quality improvement projects within the Department of Surgery at the University of Utah. Dr. Sukriti Bansal is a resident in the Integrated Global Surgery track at Baylor College of Medicine, where she's currently in her first year of Global Surgery Fellowship. Prior to her residency, she completed an MD with distinction in global health at the University of Texas Southwestern Medical Center, where her research focused on delivery of surgical care in settings in India. And Makina Haq is a medical student at King's College London, who is currently pursuing an intercalated degree in biomedical engineering at the Imperial College London. Makina is the current Vice President of Internal Affairs and hopes to expand the organizational development of Incision, which, as you already know, is the wonderful dynamic group of students and trainees who is doing the back end work of the whole conference. Makina continuously empowers students, trainees, and early career physicians within global surgery. And now I'll turn it over to Dr. Glasgow and the panelists and moderators.
Yeah, thank you so much, Dr. DeVries, and welcome everybody. I wish we could all welcome you here to Salt Lake City. It's a beautiful day, transitioning from winter to spring. The focus of our session this morning is to talk about value and what does value mean. And in my work, it's become very clear to me that the definition and the interpretation of value is really dependent upon the stakeholder's perspective. And trying to understand stakeholders' perspective as we seek to deliver high value care is very, very important. So the session today, the second session today then is going to be entitled, What is Valued? Country-specific roles of surgical systems. Now, value is defined as the regard that something is held to deserve, the importance, the worth, the usefulness of something. In this situation, we're going to hear, or in this session, we're going to hear from experts in different fields of surgery from across the globe, and their view of value on the surgical ecosystem at a district and a country level. So we begin. Bonzo.
Yeah, hello everyone. I'll be introducing our panelists. We're joined today by Dr. Maria Fernandez Jimenez. Dr. Jimenez is a professor of surgery at Universidad del Rosario and a general surgeon at Hospital Universitario Mayor in Bogota, Colombia. Her practice is
Dr. Benzel, you are muted.
Sorry about that. And she has held multiple leadership positions in multiple national and international trauma societies. We are also joined by Dr. Lara Faboya Areosan. Dr. Faboya is a pediatric surgeon in Lagos State University Teaching Hospital in Lagos, Nigeria. Outside of her clinical work, Dr. Faboya is heavily involved in the National Surgical Plan development and implementation process in Nigeria and is involved in multiple international collaborations for pediatric surgery. Dr. Marcelo Ribeiro is a professor of surgery at Pontifical Catholic University in Sorocaba, Brazil, as well as a professor of the postgraduate program in surgery in Sao Paulo, Brazil. His clinical practice is focused on trauma and acute care surgery, and he serves on the editorial board of multiple national and international. Sorry, I'm having some technical difficulties.
Maria, do you want to go over your slide?
Yes, please. So I'm going to use the next 2 minutes to explain the project that we have been developing 44 trauma leaders in Latin America and the Caribbean from different 13 countries under the leadership of the American College of Surgeons Committee on Trauma. One of the objectives of this project is really to propose a cost-effective organization and framework to establish the consultation and verification of trauma centers in our region. As you can imagine, to develop and define standards of care of countries. We are from different kinds of level of developments, public health, financial resources, and epidemiological profiles, which are great diversity. It's a challenge. According to the World Bank, Latin America is, and the Caribbean is part of the low and middle income countries, and we are really diverse. So what was our project? Was to take the resources for optimal care of the injured patient, which is a very famous document, which is the one who provides the 5,500 standards that in the States you have to verify a trauma center. And then we decided the 44 surgeons, trauma leaders who are COT and non-COT, to review the document and to define which were the standards that we can achieve or not according to our resources. So these 44 trauma leaders, COT and non-COT, we were reviewing the document, and while we were doing the translation in Spanish and Portuguese, we were establishing which were the standards that we could achieve and not. So we achieved at the end of 2016 a consensus from all the people who were participating, and it was a face-to-face or internet, and we defined our criteria. We had plenty of revisions and help and guidance from the COT. And finally, we got a document which you can see on a white book with a blue broken person there. And we were able to define where our criteria. We have a pilot site visit in the trauma center in Sao Paulo, Maciel. And finally, we are planning to have a virtual consultation from the American College of Surgeons in inspecting in the future to have trauma center verification from the American College of Surgeons in Sao Paulo under the leadership of Renato Poggetti. So we had created a future who's going to represent an increase in the care of trauma patients. And this is a voluntary decision from the hospitals. Thank you for the opportunity to show our value.
We'll hear from Dr. Laura Fobayo Adeosun next.
Thank you once again for the opportunity for speaking here. The visual picture we're looking at is both sides of a 50 naira note, which in Nigeria is an equivalent of about 1/8 of a penny, and is one of the most common expended in cash. Talking about the value of surgery, if I start by where I work here in Lagos, surgery is invaluable, with cases of trauma from accidents or violence thronging emergency rooms daily in 4 tertiary centers that we have in the city. In other states of the country, there are at least 1 tertiary center with surgical specialties and general hospitals that are expected to be able to perform bellwether surgeries. And the people of the community have now come to accept and expect that this will be available. The federal government showed their value for surgery by recently committing to the implementation of the National Surgical Plan in collaboration with some non-governmental organizations. And so the value of surgery is established. However, it becomes shaky when we get to the basics of funding health, when we get to the people. And that's why I took this particular note. It shows the faces of people, there's a woman, there's a man, there are people fishing, and the aim and part of the SDGs is to be able to make health available to people of all ages and all people. And so when we get here, the value seems shaky when people have to pay from pocket and have to weigh how much of surgical care they can get when they need based on how much they can afford. However, again, we see that within that context, in the community, there are local non-governmental organizations that rise up to sponsor specific care such as cancer treatments or treatment of congenital anomalies where funds are available. I would say that the ultimate value for us will be when every man, woman, or child in this country who can handle some money as little as a 50 naira note can walk in and get needed surgery at any time. I see many people committing to that. I see surgeons working with the policy and with the government to see this value established. Thank you.
Next, we'll have Dr. Ribeiro show his visual of value.
Okay, can you hear me? Yes, I'm sorry. I'm bored. Thank you very much for the invitation. I'm very happy to be sharing some of my thoughts about value, in my opinion here. And what I would say as a professor of surgery is that most of the time, by the time of getting up to the ranks at the university, it's kind of a natural thing to stay away from the youngest people in the medical school, like students and residents. And this is kind of scary, in my personal opinion. So what I decided to do in these last 5 years is to really focus on the young generation of Brazilian surgeons and Brazilian medical students who wants to get into this trauma surgery careers and acute care and etc. You all know that Brazil is a big country and we do need general acute care and trauma surgeons all over the place. So what I decided to do is to invest some of my time in the surgical leagues that we have all over the medical schools in Brazil. Today, as far as I know, we have one of the greatest number of medical schools in the world. What is kind of disgusting, but still, I'm trying to, like last night, I was hanging out by teams with a bunch of like 500 medical students from different medical schools, discussing trauma cases with them, trying to teach them how to focus their energy in a good quality of care for this young generation. And besides that, I'm doing as a volunteer, I travel all over the country and I spend a couple of days in the small trauma centers trying to help people to set up their programs, trying to spread the Stop the Bleed program all over Brazil. I do this as a volunteer. I just bought some tourniquets and I keep traveling. And now with the pandemic, of course, everything is slowing down, but that's the way I think we should go when we talk about value, is trying to really get these young people to get in touch with the old generation, where we can show them why we decide to follow this kind of career, which are the involvements that we can get from people to be working. Like I was on call last night, 2 nights ago, and one of my medical students said, "Hey, professor, why you stay in call like in the middle of the night in your position?" I say, "Because I think good examples, they start from the top." So this is the value that I think is more important, like the teamwork with my staff, my residents, my medical students, and trying to really get people involved in this. We do have a lot of people in Brazil that really need a good care, and unfortunately, we know that trauma is basically one of the main cause of death in the young generation here in the country. So that's my value today. That's what I'm spending my time and investing my time to try to make a difference for the young generation. Thank you very much again for this great opportunity to be sharing this session with you all. Thank you.
Now we'll hear from Dr. Christopher Anderson. Dr. Anderson is a professor, chair of the Department of Surgery at University of Mississippi Medical Center. His practice is focused on abdominal organ transplantation and hepatopancreatic biliary surgery. Dr. Anderson was foundational in building the only high-volume HPV surgery program in Mississippi, as well as starting the pediatric solid organ transplant program there. He is active in numerous surgical and transplant societies. Dr. Anderson?
Thank you for having me. This is a unique forum to me, and I'm liking it, appreciating it, and I have enjoyed the first session. And I again thank you for inviting me to this one. So I'm going to echo Dr. Glasgow's comment that value is in the eye of the stakeholder. And I put together a series of images here to illustrate kind of how I think about it. In the very rudimentary form, value equals quality divided by cost economically. And anytime you bring up that value equation, there's an elephant in the room, and that is money. And that elephant in the room can guide or misguide decisions. But in the surgical ecosystem, we have to think about everything we interact with and what the value equation is for each of those interactions and how they're not always aligned with each other. And our charge is to navigate that. So as you move counterclockwise, the first image is of a young woman and her husband. This woman is a former patient of mine who was diagnosed with cholangiocarcinoma at the age of 28, and she underwent a liver transplant and a Whipple operation, and 11 years later, she is enjoying her life, and they have had a second child since that operation. So the value equation to her and her husband is going to be heavily weighted on the quality metric, less weighted on the cost metric. So another way to think about that is they don't want the dollar store value. They want the high-end department store value for the product they're getting or for the services needed for her disease. The next image is that of my medical center. We are the only academic medical center in the state. We are the only transplant center in the state, and we're the only trauma center in the state. We're a very rural, underserved, and disparaged in many ways state. And for this center to serve all its missions and navigate staying afloat and meeting the needs of all its patients, many times the value equation, looking at it from a center level, does have to factor in the cost, and there may be compromises on the quality here and there with the bigger picture of meeting the overlying demands of the population, which brings me to the next slide, which is a heat map of the incidence of end-stage renal disease in the United States. And if you look at Mississippi, you will see we are one of the highest incidents of end-stage renal disease in the country. And so, again, you have to figure out what is the value proposition there of getting patients off dialysis in this instance, managing the cost of dialysis and getting them transplanted. So it's a bigger forum, a different view, a different stakeholder. It is population-based decisions. Then you have to bring those back into an everyday decision, which is the picture of the donor kidney you see. This allograft was turned down by many centers. It's just an example because of a very, very short ureter. Transplanting this organ into patients does increase their risk of complications. But when you're dealing with a high volume in an underserved state, and the real need is to get patients off of dialysis and get them transplanted, maybe the value equation shifts so that you identify a patient that can take this risk and this organ gets used. Similarly, if you move to the picture above that, these two women in the center of the picture are both liver transplant recipients. They each received a hemiliver of a deceased donor liver. So each of these patients made a choice to decrease the quality of their graft by taking a split allograft, which is going to increase the potential complications in order for more people to get transplanted. So they made a choice to potentially compromise the quality of their potential transplant because it was valuable to them that more patients were able to share in the transplant. And we have many examples of that. Now, I've talked a lot clinically and institutionally, and you get to my next two images, and they are of faculty and residents. And, you know, when we talk about value, we have to factor in education, we have to factor in research, and we have to factor in the support of those programs. And so it is valuable that we have faculty that win teaching awards and that invest their valuable time into teaching and education. And how do we reward that? How do we make sure they get their best experience and fulfillment from that? And we have residents who win awards and go on who do fantastic projects. And how do we encourage that as a system without losing focus or compromising in other areas? Which then brings me to the middle picture. This is a painting by the artist Jim Warren. It's an older painting, and it's not one of his more known paintings. But the reason I chose this and the reason it speaks to me is when I think about supporting faculty members or residents or staff, I always try to remember that the value judgments that they are going to make for my department, for patients, for the institution on a day-to-day basis are always influenced by their personal life. And the surgeon, he or she, is going to have something going on in their life that's weighing on them. And how do we can never fully support that. We can never fully get someone to the perfect work-life balance, but how do we factor that into our planning and as best we can so that that weight and that juggling and balancing act is as easy as possible for that individual to navigate? How can we create an environment that is supportive of whatever that individual's personal needs are, that then allows them to more easily make decisions for patients and weigh the value, risk, benefits, et cetera, on a daily basis?
Thank you, Dr. Anderson.
My answer is very complicated, and I'm sorry I took a little more time, but I think this is a complex question and influenced by a number of, from a number of angles.
Thank you, sir. Next, we're going to hear from Dr. Meziane Misk. Dr. Misk is a maxillofacial surgeon at a large public hospital in Marrakesh, Morocco. Her practice is centered on facial trauma, facial tumors, and facial congenital anomalies, particularly in the pediatric population. Her passion is public health, and Dr. Misk is actively involved with Operation Smile and AMCEL. Dr. Misk?
Hi, everybody. Thank you for invitation. I made a small video to explain why did I choose this picture, to explain what is the value in surgical ecosystem, and try to share it with you.
Hi everyone, my name is Misk and I'm maxillofacial surgeon based in Marrakesh. It's a touristic city of Morocco in the north of Africa.
We can't see your screen.
You can see my screen? Okay, just 2 seconds. Sorry, I'm not very familiar.
Just unshare your screen and reshare. Sorry, puppies. Unshare your screen and then reshare your screen.
Okay.
And just hit the bottom button instead of a specific screen.
Oh, wait.
First,
Can you
you have
see
to, no, you have to unshare your screen.
Okay.
Okay, now hit share and hit the bottom button on the right lower side of the screen where it says share. When you hit share screen, there's a button, yeah. That says test.
Does it work?
Hi everyone, my
Can you see
name
it
is
now?
Misk and I'm Max.
Can you see it now?
Yes.
Okay.
Facial surgeon based in Marrakesh. It's a touristic city of Morocco in the north of Africa. I'm happy to be part of this session to speak about the value in a surgical ecosystem at my country level. When we are speaking about surgical ecosystem, we are not talking only about surgical care. The surgical ecosystem includes many components. The most important of them is the patient, the surgeon, and the surgical organization. And to illustrate the value of this ecosystem, I choose to speak about a subject dear to my heart. For many years, I am volunteering in 2 different associations. I take this example to show that in the same country, the surgical ecosystem can be different regardless of different disease. The first one is Operation Smile. This association has many years' experience of management of cleft patients. Cleft condition is well known all over the world. These children face bullying and facial isolation. This association, rich by experience, was improved the management of this condition through the years by involving 1,000 of passionate and compassionate volunteers, training local competence, and international exchange of knowledge, setting standards, guidelines, and adequate protocol for safe surgery. This example shows that when the ecosystem is ideal, the surgical care can do miracles, and the value of surgical care is evident by rendering the smile to the child and his family. This transformative effect of the surgery change positively the life of people. My second association is AMCEL. It takes care of children affected by xeroderma pigmentosum. This condition is poorly known. It's a rare genetic disease in which there is a skin damage caused by ultraviolet light. These children are condemned to live only after the sunset. The resources allowed to the research and training program are so poor nationally and internationally that no efficient treatment is found for now. There is only a preventive medical care protocol that is too costly and badly supported by the families. The fundraising is not significant that cannot support all the costs. The only solution left is surgery to remove tumors from the damaged skin and increase the quantity of life for some patients. This surgical ecosystem is so non-effective that a question arises. Is a surgery make a real change even when it's allowed to keep the patient alive? What about quality of life? This value of surgical ecosystem is subjective and ambiguous. Thank you.
Thank you, Dr. Misk, for sharing that with us. Now we'll hear from Dr. Annette Jacobson. Dr. Jacobson is a senior consultant and head of the Department of Pediatric Surgery at KK Women's and Children's Hospital in Singapore, where she also serves as the chairman of the International Medical Program for KKH. Her practice is focused on pediatric urology and minimally invasive surgery. In addition to her clinical practice, Dr. Jacobson is passionate about medical education, expanding access to care, and improving patient quality of life and understanding of disease through her research and volunteer work. Dr. Jacobson?
I'm Dr. Annette Jacobson. I live and work in Singapore. Now, many systems exist while you provide surgical care for your patient. What is important is who pays for the service. Often a public-private partnership will be useful, and who controls access to care. And it's important that care is provided in a sustainable fashion. In 2000, we had the Millennium Development Goal number 5, which tells you to improve maternal health. In 2015, initial targets were not met, and so they were remapped into Sustainable Development Goals. And goal number 3 tells us good health and well-being for all should be available. Congenital anomalies in newborn infants are important and are the highest causes of mortality in infants and children in the US. Now, the most common being cardiac malformations, but other malformations are also common, hence the importance of pediatric surgery. In ATLS, we know you look after the mother well and she will look after the baby, and hence we look at Singapore numbers in the region, and these are not my numbers, these are WHO numbers, and this is why we think we can contribute to in the region to healthcare. And so we have trained the trainers program in Kampong Chnang in rural Cambodia, where we had a significant decrease in maternal mortality. Now, surgical care, of course, is very expensive, and we also work on access to cheap and affordable health care. And we have a program, a research program, which is temporarily on hold, which brings access to affordable laparoscopy in lower and middle income countries. This is a collaboration with Duke University, where the surgical ACP also looks at access to care, especially to team care in pediatric solid tumors. And so in order to impact the SDGs, you have to have better access to care. You have to train the team of doctors, and you have to look at who pays and is this a sustainable way of paying for the care. Thank you.
Thank you, Dr. Jacobson. Dr. Alexander, are you here with us?
I think he's stuck in the operating room.
Okay, then Makina, you want to start with our questions?
Sure. Thank you so much to everyone for sharing your presentations and your visual aids. They've been really interesting to listen to. We're going to be moving to the panel question portion of this session. So my first question is aimed at Dr. Mezian Misk and Dr. Christopher Anderson, which is, how would you define value in your surgical system? Can Dr. Mezian Misk go first?
So if I understand your question, to me, it's how do I define I'm sorry. How do I define value in my surgical system?
Yes.
So I think it's a little bit based on what part of the system you're talking about. But if a system as a whole, you know, you have to remember a couple things. You know, there is that cliche saying of no margin, no mission. And so we're at an academic center, and if we have mission, you know, 3 or 4 major missions to accomplish, the elephant in the room has to be acknowledged. And so there has to be some degree of how do we contain cost and how do we provide the highest quality we can for that cost. And then there's the bigger part you know, think about the patients we're serving. And so in a surgical area, and if we have a lot of need, how do we, you know, we can't ignore the patients who haven't made it into the system yet for the sake of the patients who are in the hospital. So although my faculty and my residents and others that I interact with probably get tired of me reminding them about the hospital's full, this, that, and the other. But the bigger picture is we're serving a community, not just the patients here. And so we have to balance, well, not balance in the right word, but we have to consider the care of the patient that hasn't made it to us yet as we're considering the care of the patient that is here. And we have to use our resources wisely. And so the conglomeration of all that is the value equation. And it's not an easy thing to do. And I think it's a minute-to-minute balancing act of that. And I think as part of the art of practicing surgery is just that, is a learned ability to balance risk and benefits with a patient, and that's no different than balancing the value equation for a population of patients, or in my instance, an institution with patients.
No, thank you so much for that answer. It doesn't look like Dr. Misk is with us at the moment, so for the interest in time, should we move on to the next question?
Yes, I think that's on me. Our next question is for Dr. Adiason. As we think about value and the value of surgical care and surgical systems, what does that translate into with regard to your community? What value do surgical systems bring to your community?
Thank you once again for the opportunity to be here, and I like that question. First, let me explain that the surgical system in the country, we know that the ecosystem involves the patients, the institutions, and the surgeons, amongst others. And the institution has different levels, the primary, second, and tertiary, all providing their cares at the various levels that are available. I would say that one of the first things that this does to the community, the people that are involved, is a value of hope. A while ago, for most people, surgery, whether it's for gynecological, obstetric, or general surgery and other specialties, was almost a doom call. They were scared about anesthesia. There were histories of poor outcomes, and people didn't want to hear that they needed surgery. While some of those still linger, there is hope now. When people come to a tertiary center or to any center that states that they can do that, they do believe that it will be a good outcome. And many of the times, this is that. So I would think that hope, that the people who then require surgery as a form of treatment for whatever their conditions are, is indeed a value. In the hospitals, in the healthcare system itself, I work in a teaching hospital, and there are many other multi-specialty centers. The surgical care that a surgeon gives, or a gynecologist and obstetrician, or other specialties offer, makes affordable a multi-specialty care that maybe other centers that are smaller may not have. And I think that that's quite relevant to colleagues who, say a cardiologist is managing a condition, he knows he can reach out to a cardiothoracic surgeon in that center who can solve a problem. That is value, being able to co-manage and give wholesome treatment to the patients. So the economic part of this is the fact that there are many surgery-specific consumables, surgery-specific equipment, which now, because demand gets higher as there are more specialties, trainees becoming surgeons, more centers, because there's definitely a shortage of almost all surgical specialties. So there's a platform for those who import surgical equipment and surgical consumables, and there definitely is a platform for those who are looking to manufacturing things, because when it comes to consumables, there are still a lot of things that we sometimes need but don't get. And so I think that platform of the possibility of an economic growth for a sector of people is also another value. Thank you.
Oh, thank you. Thank you very much.
So the next question is aimed at Dr. Annette Jacobson. So as someone who's worked in various healthcare systems across the world, I was wondering if you've noticed any differences in how value is defined across those healthcare systems. And if so, do you see any of those differences could be bridged?
Yes, I think it really depends on value to whom. So is it to the patient or to the politicians? And who is paying for healthcare, really? I think the focus has to be shifted off from the politicians to the patients and what is value to the patient should be of value to all of us, and of course, and equals to long-term value, not only short-term. So in other words, you do keyhole surgery for esophageal atresia to prevent scoliosis, which happens 20 years later, 15 years later. And that's valuable. So sustainable development goals, of course, reflect on the bottom line. But my unexpected lesson in all of this is healthcare should not be free. People should have a stake in everything. Because otherwise it is taken for granted, and healthcare should move from healthcare to health and should not be free, because people have to have a stake in what they have to live up to. Thank you.
No, thank you for that answer. I've just noticed that Dr. Misk is back. So I wanted to loop back to the question that I believe you missed, possibly due to connectivity issues, which is how would you define value in a surgical system? Dr. Misk?
Sorry for the technical problems. Yeah. As I said in my presentation, the ecosystem, surgical ecosystem is different between countries, and it's different also in the same country, depending on the disease that we are talking about, depending on the access that people have to the healthcare. And the ultimate value of the surgical system, in my point of view, is to give satisfaction to the patient. Is the final chain of our surgical system. What our aim of all of that is to heal patient, to help them and get satisfaction for him. So all the things that we do in our ecosystem, starting by nurses, surgeon, and material organization and everything, is for serving patients. And I think it's the valuable thing is to get his satisfaction. And sometimes we think that our surgical system is adding value, but sometimes we are doing things that in our opinions is right, but for the patient is not right. The expectation is very, 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 very important to satisfy. Thank you.
No, thank you. And then moving to the final question in the panel. This will be aimed at Dr. Marcel Ribeiro and Dr. Maria Fernandez Jimenez. And the question is, do you feel the values that we see in healthcare systems can be aligned over time, or do you think they're inherently going to be different? And following on from that, how can we as a global surgery community work towards common goals with these different values? Any of you two are free to answer the question.
I'm going to start. So I used to say that quality was an universal right. And right now I think that quality is really an universal obligation from physicians, from government, and from all the stakeholders. And this is what means that we need to give satisfaction, as the other panelist was telling. And what a better satisfaction to improve outcomes. And it only can happen if we work together toward the same goal. And I think that the governments and health providers are in the same, and patients and everyone is very happy to see that we are providing the best care. But it doesn't happen as a miracle and as like free. We need to work together. We need to work very hard to make sure that we are going to improve our outcomes.
No, thank you for that response.
Okay, just completing what, yeah, Maria Fernandez made my life very easy. But I do agree with you. But I think this is really a teamwork, especially in Latin America, where everything is really related to political game. So you have to play the game You have to know which people are going to be involved in each step of each level of this complex process so everything works just fine. I agree with Maria Fernanda that really today, nowadays, quality is an obligation. It's not any longer like we need to achieve quality. We need to really provide for patients a high quality of care, especially here in South America, where we have a very distinct quality of care. You go to a public hospital, have one level of care. You go to a private hospital, a different level of care. But as physicians, as like key opinion leaders in this area of the globe, I think we have to show people that doesn't matter where we're working. You have to always try to seek these goals as the most important ones. But unfortunately, what I consider here is that most of the time, the political game is the hard one to play. So we have to figure out the ways to go through it and make these dreams become true. So I think education is like a special point. We have to work with the young generations so they really get involved into it, and they're going to be the manpower to fight for this change. It's not easy, but we can see in this last 20 years that things have been changing a lot. So I think this is the way, and I thank you again for the opportunity. Thank you.
Thank you to all of our panelists. We are starting to get some questions in the Q&A box, so I will start asking, and these are open to all of the panelists. The first question we have is, one of our audience members would like to know what are the participants' thoughts on how a youth-led organization can help in achieving quality healthcare and safe surgical environments in the present and future?
Well, I think I can take that. This is pretty much what I just spoke about it. I think Lucas is from Brazil, as I could realize in the question. And Lucas, I think, yes, this young membership groups of people trying to work in improvement of care, it's feasible, but we have to learn how to play the game to have a good results on the in the focus that we want to be working with. But yes, I think it's feasible. I think you guys can, as a young generation, can move forward and try to make it better.
Thank you, Dr. Ribeiro. Any of the other panelists, would you like to comment?
I'd love to comment. I think I think the learners and the students can be very powerful in aspects of this. You know, we have a very strong Association of Women Surgeons chapter with our medical students, and that group has done wonderful things around our community and around the state, really in various aspects of a surgical ecosystem that is from community education on trauma response to organizing blood drives and other things on this campus. So while the student may not have a direct effect day to day in the operational aspects of an institution or an OR, they can have indirect effects and a large amount of indirect value in our population-based efforts.
Thank you, Dr. Anderson. I think Dr. Jacobson, you also have comments.
Yes, we have students in many of our projects, and we bring them along. It's important that the students are brought up to par with what their aims are and what your aims are, but they bring a tremendous amount of energy to any kind of project, and I would encourage you to bring students along. They make excellent timekeepers. If you're doing a parallel research project, they collect patient data, and we have been using students quite a lot in our train the trainer programs in Cambodia. Thank you.
Thank you, Dr. Jacobson. I think all three of you have brought up important points. In particular, I think that students bring a lot of energy and passion, which then invigorates all of us at all levels. The next question I have is, despite different cultures, languages, a similar finding from Ecuador, Mongolia, and Ghana found that all people identified ability to access surgical care was one of the major challenges leading to decreased quality of the system and therefore value. How do we create efficient, timely surgical access of value to patients?
I would like to answer this question. It has been my experience, my life experience in Colombia. We used to have time for definitive care. It could happen on even 1 week, 10 days, and 21 days. And it was not until that we have developing the pre-hospital care that these things started to change, and we have a better access to surgical care. So I think this is a very important topic to improve the pre-hospital care in order to get the people who are suffering to the place that needs to be treated.
Thank you, Dr. Fernandez. I think you bring up a good point that surgical care is very much part of a system and none of us can operate in a silo. Would any of the other panelists like to comment?
Yes, I would like to add to what Dr. Fernandez said about pre-hospital management. One thing I think I've found that help in our institution, because this happens a lot. First, many emergencies seem to come at night and without funds in a place where people have to pay for their investigations, their consumables, or you really can do little without that. And what we have found that is that now that there has been some form of communication established between peripheral hospitals and the institutions, such that there are actual calls made before referring these patients. These patients are expected. And during such conversations, sometimes the patients can be counseled as to come in quickly and what they might need while they present. And the other thing is there are endowment funds and things that are created, but these things can get exhausted very easily, but they are now used as things that we can start off with and patients pay back so that other people can have it. But it's almost a recurring problem if we cannot maintain that connection. Thank you.
Thank you, Dr. Favoya. That's an excellent point about communications between hospitals, even within a system. Dr. Misk?
Yeah, I want to comment about that, because we see that we notice now that the access to surgery is start to be more and difficult with this COVID pandemic. We see that there is a problem of resource, health resource all over the world. And in the countries that they are in low development or middle development, there are more deficit of resource. And for example, in my country, Morocco, people had we have more hospital and more access to surgery, but with this pandemic, we see that people start to arrive in a state of we can't really operate them at that state. They are very late, and that's the thing that we have to work on is the person and the health providers. For the numbers and to facilitate the access of surgery.
Thank you, Dr. Misk. I think a lot of us around the world are seeing that same issue with the COVID pandemic of patients presenting in a very late and difficult presentation. The next question we have from the audience has to do with balancing quality and cost, particularly in LMICs. Many times patients are admitted and suffer for weeks while surgical teams wait for them to have adequate funds for surgery. how important is it to allow patients to make their own guided decisions on what they would consider adequate quality of care, even if it's not a clinically ideal decision?
Well, let me give you my opinion here. I think this should be.
Can I talk on this? This is a very challenging question.
Absolutely, Dr. Jacobson.
No, go ahead.
I come from Singapore, where if you push the pedal on your car, you end in the sea and everybody has access. But of course, that's not the case in all of the neighboring countries. Patients often present very late and they have no access to care. And when they come, they have to pay for care. And so when I say they have to pay for, they should be paying for care and for training, I don't mean they should sell their houses or they should, you know, we should ration care that is provided to them. I think most hospitals should have a fund that is available so that care can be provided without a person who is in need of care having to worry about where the funds are going to come from as well. Access to care, of course, is also developing in parallel with other parts of the countries. And so we find that Millennium Development Goals, or now Sustainable Development Goals, actually continue to improve based on the general infrastructure of the country. So whether it be clean water, hygiene, cars, or whatever, roads, that actually increases also access to care. And even in countries that have greatly authoritarian regimes, access to care can be quite good. Thank you.
Thank you, Dr. Jacobson. Dr. Ribeiro, you had something to say as well?
Yeah, well, just some thoughts to share. Here in Brazil, we have like one of the most important free public systems in the world, where 100% of population is covered and have the right to use the public system for free. Although I would say that like 10% of the population, a little bit more, maybe 50%, have insurance companies covering their health care. So they have the chance to go to private hospitals and have a better care. But they still have a bunch of private patients who already pay for the bill. And that's what I agree with the other panelists, that we don't need to see patients selling their house and cars, etc., to have to pay the bills. But what I make clear for the patients is that they can, some part they can choose the level of care they want to have. If they want to come to a super top 1 level hospital, they have to be prepared because it's going to be expensive. But if they want to have they can choose from like a menu of different hospitals, a kind of a level of care. What I tell my patients that I will do both. In a free, in an academic hospital, that everything is free, but it's not a fancy place with the hotels and everything. And maybe in a very super fancy hospital, if they want to spend money, the care is going to be the same. The doctors are the same, and the teams are the same. So it's really hard. I think it would be fair for everybody to have a high level of care independently, where talking about public or private hospitals. But unfortunately, in Brazil, this is not the way it works. So just a quick comment on our public health system in Brazil.
Thank you very much, Dr. Ribeiro. Unfortunately, we were out of time. I think Dr. Glasgow, you had some quick closing remarks.
Yeah, just real quickly. Thank you so much to all the panelists and all the great questions. It's very clear that our value has to be our beacon. We have to lead toward value, and that's optimizing the quality of care. That's optimizing access to care and eliminating disparities of care. It's also dealing with appropriateness of care. We need to be stewards of cost, of resources. Cost is also a measure in efficiency and how to adjudicate or how to distribute resources in a fair and equitable way. The one thing that's very clear in all of our panelists' message is that the stakeholder who reigns supreme is the patient. It's the health of the patient, the health of the community that should be driving our value work. And then we also heard from two of our panelists of the importance of leading on value and mentoring and bringing forward the next generation of leaders, of surgeon leaders. The pipeline efforts to cultivate the next generation. As one thinks of one's impact in academic surgery, you yourself have your own practice, but if you can train people to lead, to be effective in their work, you're amplifying your message. And I think we heard that loud and clear from our panelists, as well as the importance of bringing forward the next generation and empowering them in their work and their communities. But thank you, everybody. Fantastic session. And congrats to everybody on your tremendous success and contributions.
Thank you so much, Dr. Glasgow, and everyone on the panel. I would like to also thank all the moderators and panelists from earlier today. We are out of time, but before we leave, I would like to remind everyone that we have session 2 happening tomorrow, or second part of the sessions, I should say, so sessions 3 onwards, happening tomorrow the same time, 3 p.m. GMT to 6 p.m. GMT, which is 9 a.m. CST to noon CST. Tomorrow's sessions are handled in a form of a meeting, and we're very excited to have you there with us. If you are interested, the Association for Academic Global Surgery also has their spring meeting in 1 hour from now, and I posted the bit.ly in the chat moments ago. Thank you for everything, and thank you for joining us today.
See everybody
Thank
tomorrow.
you. Thank you, everybody.
If the panelists could turn on their camera for a quick picture, Dr. Jacobson, Dr. Misk, and everyone say cheese. 1, 2, 3. Cheese. Thank you so much.
Please share the picture with us.
Absolutely. I'll send it to you guys. Thank you so much.
Thank you very much. Thank you, everybody.
Thank you, Santiago.
Bye. Thank you everyone for coming
Thank you,
today. It's been
Santiago.
fantastic.